Perfect.
So what's up, guys? Hey, it's Stephen Dunn here from CORE Therapy and Pilates, and I'm here with my brother, Dr. James Dunn. He's in from Northern California, and he's a urogynecologist. So we're going live today on my business Facebook page. We're also going live down here on our marketing page. So we're going to be looking up here, but we want both groups to hear this message. This message down here for the marketing group, this has nothing to do with marketing. This is going to be clinical, but everyone here working with personal training that typically has questions about pelvic floor health and things like that. So I think it's going to be very applicable to this group. But to the group up here, my business page, we get so many questions in the clinic on a daily basis about pelvic floor strengthening, about Kegels, about all these things that come into play whenever we're working with back pain. A lot of back pain is contributed to weakness in the core, weakness in the abdominals, weakness in the multifidus, but also weakness in the pelvic floor. So what I wanted to do today is have Dr. Dunn go over a little bit of, first of all, what is a urogynecologist? Because that's a question I get a lot whenever I discuss what he does. And then a little bit of I'm going to ask him a few questions to kind of see if my audience can get some helpful information out of this. So first of all, Jamie, Dr. Dunn, tell me a little about what is a urogynecologist.
I get asked the same question, and I've been doing this for a long time, but a lot of confusion. I started off as an OBGYN doctor and did 4 years of residency, but then went back for 3 years of additional training in pelvic floor therapy, conditions like urinary incontinence, fecal incontinence, pelvic prolapse. So primarily female urology with a special interest in pelvic floor anatomy and pelvic floor surgery.
And a way I kind of explain it when people ask me questions about like, well, should I see my OBGYN or should I see a urogynecologist? What I explain is, well, if you've ever had your wisdom teeth pulled, you can have your wisdom teeth pulled by a dentist. But if you go to an oral surgeon, he's a little more versed and trained, and he does more of it. And
Correct.
So you could go see a regular OBGYN to do most of what you do, correct, but that's not what they do all the time, correct?
Yeah. My 75% of my practice is exclusive pelvic floor therapy and pelvic floor problems.
Do you do any OB at this time?
I do not deliver babies anymore.
Gotcha. That's what I thought. So there's the kind of the differences between the two. Now, anyone that comes on, I see we've got a few people joined in. Just if you have any comments, put them below, and we'll make sure to answer your questions. So my first question is can you tell us a little bit about urinary incontinence, stress incontinence, as far as how frequent it is, and a little bit about how you treat it?
For sure. It's the number one consult that I get is urinary incontinence, and then urinary incontinence is a broad category with multiple types, and that is what we try to do with their first consult is figure out and tease out, is it stress incontinence with coughing and laughing and sneezing and exertion,
jumping is what we hear,
jumping and trampolining. I hear all of those questions like that. And then the other type of incontinence that's not as common but still very prevalent is OverActive Bladder, which is a syndrome of urinary urgency, urinary frequency, and getting up at night too many times. So those are the two most common. And then there's another group that has a little bit of both of those types, and we call that mixed urinary incontinence. And so that's kind of sums up the majority of the incontinence that I treat. As far as treatment and options, that's another whole topic. We could talk about that for an hour, but I'll give you the fast consultation
Cliff
version.
Notes.
The Cliff Notes. So
do they still make Cliff Notes? I don't even know if they still make Cliff Notes, but they sure made them when I was a kid.
English, I did not like English. So that's why I went to med school. So for stress incontinence, and for overactive bladder, the best treatment is going to be your pelvic floor therapies and what I call behavior and lifestyle modifications incorporated with pelvic floor therapy. Having women practice their Kegels, and more importantly, teaching them how to do the Kegel exercises correctly. We've been able to see that there's probably 20 or 30% of women that don't know how to isolate their muscles, and so they need extra training. There's medications for overactive bladder, there is some neurostimulation therapies out there that stimulate the pelvic floor and the sacral plexus. Botox is my new favorite treatment for overactive bladder. It doesn't help with stress incontinence. I do a lot of Botox injections there in the office with the cystoscope. And then last resort for stress incontinence is the surgical things that I do, the slings and injections. But like I mentioned, I try to get everyone to work on behavior and lifestyle changes, and pelvic floor is my go-to for women with incontinence.
Now, you mentioned the last step being a surgical intervention. Can you talk a little bit about the program that you've run and the success that you've had with people that, I can't remember the number, but it was over 80% of people that are not having to have surgery because of the program that you're taking them through. Can you talk about that for a second?
Yeah, oh yeah, definitely, because that's my go-to, because it actually treats both types of incontinence. So it treats overactive bladder, which is sometimes called urgency incontinence, and it treats stress urinary incontinence. And I just call it pelvic floor therapy. It's a comprehensive program with my nurse or my nurse practitioner, and you come in for weekly visits, about 30 to 40 minutes per week per visit. We do about 6 to 8 visits to get the maximum benefit. And as you mentioned, about 70-80% plus of patients are getting significant benefit and are able to avoid surgery and are able to avoid taking medications. In the program, it's a combination, excuse me, of behavior changes, meaning how much do you drink and how often do you go to the bathroom, and of course teaching and reinforcing the pelvic floor exercises. We have biofeedback to help women isolate their pelvic floor muscles stronger and better, and then we do use an electrical stimulation protocol to kind of basically overstimulate the pelvic floor to help regenerate muscles and nerves and get the pelvic floor working like it's supposed to.
Do these women learn a program to do at home in between those visits, in between those weekly visits?
Right, yeah, so that they definitely get homework, and we call it homework because if you don't do the homework, you're not going to learn the lifelong things that you need to do the rest of your life as far as to maintain the pelvic floor. Most of the women have had children 20 years ago, 30 years ago, and completely forgot about their pelvic floor strength, and we always joke and say use it or lose it, and we're trying to help them rebuild it and relearn it. And then we also have a home device that is available that women will sometimes use if they don't want to keep doing the program on an ongoing basis, which works great. So
and that's like a portable e-stim type of unit?
Yeah, it's a vaginal probe with a electrical stimulation protocol.
Gotcha. Well, it's interesting. As a PT who specializes in back pain and Pilates, we specialize in Pilates. A lot of my clients come in with back pain, and they don't tell me about the stress incontinence or those things. They just tell me about the pain and the things they can't do because of the pain. And then typically when we take them through the program, on our program being some hands-on manual therapy and Pilates and gyrotonic training, once we take them through the program, a lot of times 2 months, 3 months later, they say, well, I'm no longer having these issues with stress incontinence. Even though they didn't tell me that at the beginning, we're re-educating the pelvic floor and teaching core work with everything we're doing. And what he said is that lifestyle change. And if you go in and do something 30 or 40 minutes or an hour a week and you don't make it a part of your life the rest of the time, it's kind of pointless. It doesn't seem to carry over. Right. And so we teach homework to all of our clients, and the clients that do really well are the ones that do the homework, and the clients that don't do so well, they expect us to fix them. And if people can take a little bit of ownership in this process, which it sounds like you're allowing people to empower themselves through the process before they have surgery. And by the way, this is a surgeon giving people all of these opportunities to avoid surgery. So that's one of the coolest things, that when him and I chat about this, and never did I realize when we ended up in our own fields that our fields would kind of be so similar, and we would be able to have these kind of conversations. But I now know that all of my clients, I shouldn't say all, but a lot of my clients have pelvic floor issues because we specialize in treating women that are 45 and above. And again, they've had babies 10, years, 20 years ago. So now the last thing, we're going to wrap this up, but I want you to just go over a little bit of anatomy. I get asked about the pelvic floor anatomy frequently, and I just kind of reference it as a sling underneath the pelvis. And I don't get into any more detail than that because it kind of confuses people. But I wanted you to just briefly go over the anatomy, and this will be the last question, unless we get any questions that come up on the board. But just kind of go over the anatomy, and then we'll wrap it up here in a moment.
Yeah, the main thing of the pelvic floor is you have the bony parameters of the pelvis, and they're not going to change because this is fixed. But the pelvic floor muscles basically act like I call it a bowl, and so it's a pelvic floor bowl. Of course, the bladder, the urethra, the vagina, the GYN, uterus, and pelvic and organs are there, and of course the rectum and the anus. So you have three very important functions coming through the pelvic floor in a tight space, and that's why they say, when you have dysfunction of one, you can have dysfunction of all three. So it's a tricky thing. But think of the levator plate. It's called the levator ani. It has three muscles. They all have a bunch of long names, so I'm going to just call it the levator ani plate, and because it's a lot to memorize.
It's a mouthful,
and it's too much. It's like just you want the big picture. The big picture is everything sits on the pelvic floor. It has tonic strength that just is resting and holding, but more importantly for incontinence is that quick squeeze that the pelvic floor does to hold urine and to keep women from not having urinary or fecal incontinence. And so, it's very interesting how it has to have the support, but it also has to have the function to hold, our daily activities, our, urination, defecation, and obviously sexual response. So it's, and of course it's innervated by the pudendal nerve, which comes off of the sacrum 2, 3, and 4. It's called the sacral plexus, and so the pudendal nerve, you'll hear that a lot, innervates the levators and gives its strength.
And we see a lot of people with L5, S1 nerve issues, with sciatica issues and things like that. So that's just a little further down the chain. So the sacral nerves are coming out down through here in the sacrum, right through these little holes. You can see them right there. Versus a lot of what I deal with back pain is nerve problems from the disc that are coming right here as the lumbar are stacked up. So,
yeah, for sure.
All right. Well, that's all we got for you guys today. We're going to be putting together some more information moving forward. We're going to put together basically that little program that he does. We're going to make a course out of it and have available in the next few months. So we just wanted to kind of come on, discuss a little bit of information, and anyone has questions, reach out to us through the Facebook group, reach out to us through the Facebook page, and we'll be putting some more information out about pelvic floor health, because again, we see how important it is on a day-to-day basis with all the folks that we treat. So that's it for today. We're excited to have Jamie in from California.
Austin,
His son was in town as well, so we all got to hang out last night, and had my nephew and my brother in town, and here we are talking about pelvic floors at dinner with my kids and his kids. They were loving it. So, all right, guys. Well, that's it for today. Y'all take care. Have a fantastic day. It's gorgeous out, and go get out, be active, and we'll see y'all real soon. Peace. Take care. Bye now.